Okay, guys, so this lecture is about the anticoagulants and antiplatelet drugs. And if a patient is on anticoagulant or antiplatelet drug therapy, so what precautions we should take if we have to perform certain dental surgical procedures. Let's see what are these drugs and like which class do they belong to. They are from the blood coagulation modifier group. Blood coagulation modifiers are those drugs or those medicines which affect the blood coagulation, and they are like different types of medications which include anticoagulants, antiplatelets, thrombolytics, as well as associated reversal agents. So anticoagulants and antiplatelet drugs are used to prevent the blood clot formation. Thrombolytic drugs, which we also call fibrinolytic drugs, they are used to break up the blood clots, and heparin antagonists, anticoagulant reversal agents, and platelet stimulating agents are used to reduce the risk of bleeding. Anticoagulants. The most commonly prescribed anticoagulant is warfarin. Well, newer types of anticoagulants are also becoming quite prevalent. And these are rivaroxaban, then dabigatran, epixaban, then edoxaban. These are their trade names. Both warfarin and these newer alternatives are available in tablet or capsule form, means oral formulations are available. Well, there is another anticoagulant, which is heparin. It is administered with the help of an injection. Antiplatelet drugs. Well, aspirin, as we know that it is an anti-inflammatory drug. It is used for controlling the pain and is also an antipyretic, means fever-reducing medicine. Well, it is also a drug which was for the first time used as an antiplatelet medication. It functions as a cyclooxygenase inhibitor. So other oral antiplatelet medications are clopidogrel, then ticagrelor, then prasugrel, then cilostazol, and dipyridamole. Glycoprotein 2B and 3A inhibitors such as tirofiban and eptifibatide are available only as parenteral agents, and parenteral means which are injectable, and are utilized during the acute phases of acute coronary syndrome. Well, if we look at the mode of action of the antiplatelet drugs, they work by inhibiting various pathways involved in platelet activation and aggregation. So they prevent clot formation or thrombus formation. Well, let's see what are the various types of antiplatelet drugs are. These are cyclooxygenase inhibitors, ADP receptor inhibitors, then phosphodiesterase inhibitors, glycoprotein 2B and 3A inhibitors. Well, aspirin, it is the cyclooxygenase or COX inhibitor. It inhibits the thromboxane A2 production, reducing platelet aggregation. Clopidogrel, then ticagrelor and prasugrel, these are the ADP receptor inhibitors. They block ADP receptors, so prevent the platelet activation. Adenosine diphosphate. Cilostazol, dipyridamole, these are the phosphodiesterase inhibitors. They increase CAMP and CGMP levels, inhibiting the platelet activation. Tirofiban and eptifibatide, these are the glycoprotein 2B and 3A inhibitors. They block fibrinogen binding, preventing the platelet aggregation. Well, each class of antiplatelet drugs, they target different pathways in the platelet activation and aggregation process, providing a comprehensive approach to prevent the clot formation. Mode of actions of anticoagulants. Anticoagulants, they prevent blood clot formation by interfering with various components of the coagulation cascade, which is the process the body uses to form the clots. So here we are few which we will discuss, different classes. The vitamin K antagonists. Then the direct oral anticoagulants, they are of two types. The direct thrombin inhibitors and direct factor 10A inhibitors. Then indirect anticoagulants. Let's see the summary of effect of these drugs. Warfarin, it is vitamin K antagonist. It inhibits vitamin K dependent clotting factors, reducing the clot formation. Dabigatran, it is the direct thrombin inhibitor, directly inhibits thrombin, preventing fibrin formation. Then the rivaroxaban, apixaban, and adoxaban, these are the direct factor 10A inhibitors. So they directly inhibit the factor 10A and prevent the thrombin formation. Heparin and low molecular weight heparins, they enhance the antithrombin 3 activity in activating thrombin and factor 10A. An example is enoxaparin. Then fondaparinux, it selectively enhances the antithrombin 3's inhibition of factor 10A. Blood tests which are used for various coagulation modifiers. Blood tests for antiplatelet therapy primarily focus on assessing the platelet function and ensuring effective inhibition of the platelet aggregation. Well, traditionally, bleeding time is used to check the efficacy of these drugs, whether they are working properly or not. So the bleeding time is increased or not. But other more reliable platelet function tests are also available, like Verify Now, platelet aggregometry, and PFA100. They are also used along with the clinical monitoring to ensure optimal therapeutic outcomes and patient safety. The blood tests for anticoagulants. Blood tests for monitoring anticoagulant therapy are essential for ensuring the safety and efficacy of treatment. The choice of test depends on the specific anticoagulant used. Warfarin, it requires INR monitoring. We will discuss what INR is. Direct oral anticoagulants and low molecular weight heparins, generally they require less frequent monitoring with specific tests available for special situations. Regular clinical assessments and appropriate use of laboratory tests, they help manage and adjust anticoagulant therapy effectively. What is this INR? INR is International Normalized Ratio test. It is a standardized measure used to assess how long it takes for blood to clot. It primarily uses to monitor patients on warfarin therapy to ensure that their blood thinning level is within a therapeutic range. INR is a calculation based on the prothrombin time, which measures the clotting tendency of the blood. The prothrombin time varies depending on the laboratory and the reagents used. So the INR that standardizes these differences to provide consistent results. And its formula is patient's prothrombin time divided by the control prothrombin time and whole raised to the ratio of ISI. This ISI is International Sensitivity Index, which is specific to the reagent and the instrument used in the test. Let's see the values of INR. Normal value, that is 1, and it indicates that the blood clotting time is normal. This is the standard baseline for someone who is not on the anticoagulant therapy, as it reflects the average prothrombin time of a healthy individual. But if a patient is on warfarin therapy and their INR value is 1, that is a major concern. It means that their antithrombotic effect of the drug is not in effect, and we have to either adjust the medication or we have to look into the other factors as well. So the patient's physician should be immediately contacted. Therapeutic INR ranges for warfarin when they are using it, and it is not one. So what are these? Most conditions, typically the target INR range is 2 to 3. This includes conditions such as atrial fibrillation, deep venous thrombosis or DVT, and pulmonary embolism. Mechanical heart valves. In those cases, a higher target range, often between 2.5 and 3.5, may be required to provide adequate anticoagulation. Regular INR monitoring and patient education on factors affecting INR are crucial and safe and effective anticoagulation therapy. INR and dental extractions. Normal range for procedure, like for most of the dental extractions, an INR of 2 to 3 is considered safe. Some guidelines suggest that dental procedures can be performed safely even if the INR is almost just below 3.5. But this can vary based on the patient's overall health and specific clinical guidelines. So pre-procedural INR should be checked, and it is almost 24 to 48 hours before the procedure that patient's INR should be checked, and we have to be sure that it is within the range for the procedure, normal range for the procedure, that is 2 to 3. Dental extraction and local measures for patients who are on anticoagulants. So local hemostatic measures use local measures to control the bleeding, such as pressure, apply firm pressure with gauze. Hemostatic agents can be used. Use agents like oxidized cellulose, that is Surgicel, gelatin sponge, that is gel foam, or fibrin sealants. You can also place sutures to control the bleeding, or you can use tranexamic acid. Ask them to rinse with or apply tranexamic acid to reduce the bleeding. Well, like always, when we extract a tooth, we give our patient some post-extraction instructions. So we have to tell them all those instructions, all those steps they have to take after the extraction when they reach home. And apart from that, we have to emphasize on certain other things as well, because these patients are on anticoagulant therapy. So providing detailed post-operative instructions, then we have to tell them avoid vigorous rinsing, spitting, or using straws for the next 24 hours, apply ice packs to reduce swelling, maintain a soft diet, and avoid hot foods or drinks for the first 24 hours. In case of high values of INR, what we have to do? So increased bleeding risk will be there, and INR above 3.5 significantly increases the risk of bleeding during and after the extraction. Consult the patient's physician, and if possible, ask them to adjust the dose. So consult with the patient's physician or anticoagulation clinic to adjust the warfarin dose temporarily if necessary to bring the INR into a safer range before the procedure. Or if possible, delay the procedure if the INR is too high. It may be necessary to delay the extraction until the INR will come within the acceptable range. Or other than that, we have to contact the physician and go for the coordinated care, ensure clear communication between the dentist, the patient's primary care physician, and any specialists managing the patient's anticoagulation therapy. Well, at times, some question could be asked in the examination about the alternative anticoagulation method, what it is. That's why I'm covering it over here. Temporary switching. In some cases, particularly for patients at high risk of thromboembolism, the physician may consider a bridging therapy. And what is that? This involves temporarily stopping the warfarin and switching to a short-acting anticoagulant like low molecular weight heparin before the procedure, and then resume warfarin after the procedure is done. Special considerations for the patients who are taking direct acting oral anticoagulants. Well, a 2015 guideline from the European Heart Rhythm Association updating a 2013 guideline indicates that certain dental interventions such as extraction of up to 3 teeth, periodontal surgery, abscess incision, or implant placement, they do not necessarily require discontinuation of the newer anticoagulants. Two narrative reviews published in 2015 recommend conservative approaches such as extending the interval between the last anticoagulant dose and the dental intervention, particularly for patients at higher risk of bleeding or with an increased risk of perioperative bleeding. Therefore, a patient who takes their anticoagulant in the evening can take their last dose in the afternoon on the day before surgery so that there will be a little bit more gap between the last dose and the procedure which we are going to do. Special considerations for the patients on warfarin. In its latest statement, the American Academy of Neurology recommends that patients taking aspirin or warfarin for stroke prevention continue their medications during dental procedures. A 2015 systematic review on the management of dental extractions in patients on warfarin found that those with an INR of 3 or less could safely maintain their regular warfarin regimen before the procedure. Well, a 2016 clinical practice statement from the American Academy of Oral Medicine, based on a literature review, concluded that moderately invasive oral surgery like uncomplicated tooth extraction is safe with an INR of even up to 3.5. And some of the experts, they even consider it is safe when the INR is up to 4. A special consideration for the patients on antiplatelets, no matter single or dual therapy. So a 2020 systematic review and meta-analysis found that bleeding rates after minor oral surgery were clinically similar in patients on dual antiplatelet therapy, aspirin, and any other agent. More commonly, it is clopidogrel. Single agent therapy or no antiplatelet therapy, bleeding when it occurred was managed with local measures and no fatal events were reported. So authors, they advised, like authors of that systematic review, they advised against interrupting dual antiplatelet therapy before minor oral surgical procedures. A 2013 systematic review also found no significant increase in postoperative bleeding complications from invasive dental procedures in patients on single or dual antiplatelet therapy. So over here, we are done with this lecture, and soon I will come back with another important lecture for you guys. Thank you very much.